Thank you for listening to this PYA webinar recast. PYA is pleased to offer this alternative way to access our thought leadership. This is a recording of a previously delivered webinar. The information is accurate as of the date of the original event. The video recording, slides, and associated material for this and all PYA webinars are available on our website at pyapc.com. This podcast is for educational purposes only. It is not intended to be used as legal advice or an official opinion.
Good morning, everyone. Welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is 2025 Medicare Physician Fee Schedule Final Rule, Part 2. PYA is happy to present today's webinar on this important topic. With that, I would like to introduce our presenters, Valerie Rock, Carine Leslie, Brian Raabe, Katie Croswell, and Kimberly Campbell.
Thank you, Jen. Appreciate it. Welcome everyone joining us today. Appreciate you joining us and listening in to this update, this part 2 of this update. If you didn't hear part 1, please do take a listen to that. It's on our insights page under our regulatory roundup page. So please take a listen to that. That includes all things from the kind of beginning, telehealth, things like that. It also includes the 60-day rule change. And if you're not aware of that, because it wasn't listed actually in the CMS release, please do listen to that because it'll be important to talk with your counsel and inside counsel and outside counsel to get prepared for implementing that now. We're already starting to use those new guidelines now, so it's important to know what's going on with that. So with this, today I have a panel with me that was on the part 3 of the proposed rule segment that we did last time, and want to introduce them. So again, I'm Valerie Rock, principal with PYA. I oversee all of our revenue integrity services. This team is part of our management team for our regulatory compliance area, including revenue and compliance advisory services. So we have all nature of expertise of revenue integrity, regulatory compliance, managed care compliance, and reimbursement. So we're coming with a whole bunch of different angles on this content today and want to share with you those finalized updates within the physician fee schedule. So Carine Leslie is a senior manager in our revenue integrity services. Brian Raabe's manager in our managed care services. Katie Croswell crosses between our revenue integrity and regulatory compliance, and Kimberly Campbell is a manager in our revenue integrity services line. So appreciate all of you listening in today, and welcome your thoughts and your questions in the chat that we will respond to later after the session. And do remember that that this session is recorded and is available later on today. So appreciate you tuning in. So first, we're going to talk about global surgery payment changes and what was finalized. Then we're going to walk into the E&M changes, especially that G2211, the preventive services, behavioral services update, outpatient therapy, opioid treatment programs, and then skin subs to round it out. So welcome all of your thoughts today. So I'm going to start with the global surgery and turn that over to Brian so you can share with us. Thank you.
Very good. Thank you, Valerie. And then just to, of course, want to echo Valerie's comments. Just really excited to have, I'm grateful to have everybody with us today. Look forward to presenting for you and covering a whole kind of host of topics here today. But to get us started, we'll talk about global surgery payments and global surgery packages and changes that have been made, really to try to improve the accuracy of how those services or those packages rather are being paid. Just as kind of a quick recap, this is sort of a snapshot of where it's kind of been a long and winding road to get to this point. But this is sort of a snapshot of where we stand right now in 2024. There's approximately 4,000-ish codes, CPT codes that are valued as global surgery packages. They're broken up into, depending on the nature of the procedure, and this is the intensity of the procedure, either a 0, a 10, or a 90-day global period. So just as a quick kind of to get some context, a 0-day, procedure rather that would fall into the 0-day category is typically minor procedures, endoscopies and things like that. 10-day would be slightly more intense services, still kind of in the minor procedure bucket. And the 90-day post-op, the 90-day global packages would be major procedures. But these packages, include essentially all of the services that are associated with the procedure itself, so including the preoperative visits, the surgical procedure on the day of the surgery, and post-op visits and any discharge services that might be applicable, as well as any other services that might end up being required outside of office visits or follow-up visits, but still related to the procedure itself within that post-op period. There we go. And kind of like I touched on a little bit, it's got a very, very brief history sort of summarized here, but it's been a long road historically with global surgery packages. A lot of, not unlike a lot of other topics in healthcare, but a lot of proposals to change how the services or the packages are valued. Things such as eliminating the 0, 10, and 90 concept altogether. But all of that essentially is either failed to come to fruition or has been never moved forward. So we're kind of at the point that we are. But one of the pieces I did want to specifically talk about was CMS's efforts around collecting data regarding the count and the levels of post-op evaluation and management services. That I mentioned this because it kind of ties into some of the changes that are actually finalized for 2025. But basically, there's the concern is that they're in the real world, there's fewer post-op services, post-op E&Ms being rendered than what are considered by CMS and by when the package is being valued. Other kind of flaws that have been identified over the years that are attempting to be addressed is that it generally assumes the concept of global surgery packages assumes one model of care. So essentially that the same provider sees the patient preoperatively, and the decision for surgery is made, perform the procedure, and then provide 100% of the postoperative follow-up visits and care for the patient. But the real world is kind of, that doesn't always work out that way for a whole host of reasons. Patient might end up with a different provider, in terms of follow-up. To some of the changes that are being proposed, or not proposed, but that were initially proposed and now finalized, are to allow some of these scenarios to be captured and paid a little bit more accurately. Go to the next slide. There we go. So again, just a bit more detail on some of the terminology and some of the components of global surgery packages that we'll be talking about and that are updated in the final rule for 25 relates to transfer of care modifiers. And so this kind of ties to the single model of care that I talked about. But as it stands today, there's 3 different modifiers that can be reported that allow the package to be essentially split into separate components. And those are modifier 54 for the surgical care only, 55 for the postoperative management only, and then 56 for the pre-op management. So I've got an example pulled in with a CPT code for a total hip arthroplasty. It's a 90-day code, so that's obviously in the major procedure bucket. And then you can kind of see how it's been defined, and the value for that package is broken up or distributed rather across the pre, intra, and post-op periods. And so for 2025, the pieces that were on the previous slide, the three modifiers, those still remain. There's no change. Those are still there. Those are still an option for physicians, the proceduralists, and other providers to report when certain criteria are met. But one of the big changes is a revision to this transfer of care policy, primarily to address instances where the post-operative care is provided, furnished by a provider other than the proceduralist, the one that performed the surgery, and also in a different group practice, not in the same group practice as the proceduralist. But specifically when there's an informal but expected transfer of care. The other change for 2025 is the introduction of a new add-on code, G0559, which is intended to account for the resources involved when a physician other than the proceduralist is taking on the postoperative care for that patient when there has not been a formal transfer of care in no formal handoff for that patient, that particular patient. And we'll go into a little bit more detail on both of these pieces here on the next couple of slides. And so for 2025, the transfer of care modifier 54 is, as I mentioned, the one that is intended for the surgical, for it to be reported by the proceduralist, indicating that they are providing only the surgical care piece of the 90-day global surgery package. So this concept in this change wouldn't apply to procedures that are in the 10-day global or 0-day. And the term that's used that I particularly like from the final rule is that they describe it as they're broadening the applicability of this modifier, which is, I think, a good way to describe it. That it's the current kind of use for the modifier is when there is you're allowed to report that when there's a formal documented transfer of care, but it's being, they say, broadened. To me, it's relaxed a little bit maybe, but that can now be reported when there's an informal, non-documented, but an expected transfer of care between the proceduralist and another provider to provide the post-op care. One thing that is not clear that we're able to kind of, based on what's available in the final rule, is where the pre-op care falls in this change. It's pretty, to me, it makes sense that when you're appending modifier 54, you're capturing the surgical care only. There's also obviously the pre-op care, the decision for surgery, the visit that's, prior to the date of surgery itself. So it's still not quite clear in the comments or any of the responses in the final rule. I wanted to pull in and call attention to this snippet, this sort of sub-bullet here from one of the recent claims processing manuals from Medicare, but essentially indicating that you would assume the physician who bills the modifier 54 and all the criteria that I mentioned are met regarding the transfer of care, that it's assumed that they also provided the pre-op care and are paid accordingly. So that's something, if you're in a role and are in a position where you're dealing with the global surgery packages and looking at these payments and how physicians are billing for these services and appending these modifiers, it's certainly something to be mindful of and continue to watch for as we move into 25 and some of these changes begin to take effect. But did also, or sorry, go ahead, Valerie.
Yeah, I think just to add something here, I think what we're seeing here is that it seems like they may be getting ready to change the way that they're paying. So while this is in the manual right now, stating that you don't use the pre-op modifier, you just use the surgical modifier, and when you use that, you get paid for both elements. it looks like they're starting to shift to only paying that surgical amount related to that RVU. We even saw in MLN Matters that was updated in, what was it, Carine, November, that was saying, you know, basically highlighting this 56 modifier for the pre-op portion. They have historically said don't even use that modifier, and now it seems like it may be changing. So even if you're doing formal transfers of care, there may be a change to the way that we bill in the future. So keep an eye out on this, because it's not clear if they're going to shift their policy with this and start breaking this down further or not. So, you know, if you are doing the non-formal transfer of care and just billing for the surgical, you want to make sure you're getting paid for the pre-op and the surgical, and not just the surgical if you're doing both. But, you know, this is kind of on the table for something to watch out for. Thank you, Brian.
Yep, thank you, Valerie. And then the last piece, just to add on this topic, is that these changes there is not any going to be any change related to how separately identifiable E&M services are captured and billed. So pending the usual modifier there, no changes in how those services are handled when it comes to the 90-day global periods. The next topic on global surgery packages is, as I mentioned previously, the new add-on code G0559. This was initially proposed in the proposed rule as GP01C, but this is intended to, this is kind of the other half, I guess, of the same concept of handing off the patient. The post-operative care is managed by a different provider. The intent for this code is that it would be reported by that the provider that's taking on that post-op care as a way to reflect the additional time and complexity and costs with taking that patient on, given that the surgical procedure was performed by another physician. And so what I've included here is the full, very lengthy description of the code. This is the description that was finalized for 25. It's not, there were no changes in the specific description from what was proposed, but wanted to call out with the underlined section that the code is only expected or allowed to be reported once during the 90-day post-op period. It's expected that that would be with that first visit following the first visit with the post-op or the provider that's providing that care. The thought being that you're only incurring this additional time and costs when you're seeing the patient for the first time. Once you've gathered, and there's some examples I'll go into on the next slide, but once you've done the work of collecting notes and getting information and records and reviewing the patient's, how the patient handled the procedure, all of those things, you're doing that with the first visit, but then from that point on, you're just, it's the same amount of work as, you know, essentially an established patient. But this would be reported separately with the appropriate E&M code for the visit, again, once per the 90-day global period. And then another kind of question mark that remains is the relationship between this add-on code and G2211, which we'll talk more about here in just a bit. But something, again, to kind of be on the lookout for, depending on the nature of that handoff and the follow-up care, how those services, what the guidance will indicate as to what's allowed in terms of reporting those together, or if they are not allowed to do so.
Right. So in the final rule, there's nothing stating that you can't bill those two together, and you would kind of assume that those are two different reasons to bill each code. So the complexity of, you know, getting the patient back after surgery and evaluating all that post-surgical information versus that focal point of care, because it's probably they're probably coming back to the primary care physician, so they're going to be assuming that care and that being that focal point of all of the care. So it seems like both of those would be billable, but we want to put the radar up to watch for that to be potentially edited in the future. Of course, the 25 modifier is the only reason why it's being edited at this point, and you wouldn't have a 25 modifier on this. So presumably it would be billable, but to, keep an eye out for that.
I'm just wrapping up some of the ideas behind the new add-on code. What I've listed here are some examples of what the final rule describes as elements that would support using this code. So again, the idea is to boost the payment to that provider that's taking on the post-op care for the patient. So like I mentioned, reading through the records from the surgical note, elements of the procedure, success, complications, any of those pieces, any research that might be required in terms of what the post-operative course of treatment might need to look like, the usual probably evaluation, physical exam, and then working to coordinate with the proceduralist if there's any questions, concerns, anything like that might come up. So those are all pieces that would be captured or reflected with this code. And again, the expectation is that that should only really, the burden of going through all of these steps would only be felt with that the first follow-up visit. And then in terms of valuation of the code, this was what's described in this second bullet, and then the table is consistent with what was in the proposed rule. But CMS identified CPT 90785 for interactive complexity as the closest comparator for the work that's being described by G0559. And so I've got sort of the work RVUs and what they expect the physician, time to be for these services. And you can see that it's essentially, they took the values for how 90785 was valued and cut it in half. And so they finalized that. So that would come with reporting this code in addition to the appropriate E&M code, would be an additional 0.16 work RVUs, and they estimate approximately 5.5 minutes of physician time would be for providing these services. And then I'll now hand it over to Kimberly for some updates on next.
Yeah, let's dive into G2211. It's clearly was and continues to be a hot topic of discussion. So let's go into the changes. Just a quick recap. This is the additional complexity code that you can add if the provider is either one, the continuing focal point for all needed care, or two, when the care is part of that ongoing relationship to manage a single or serious complex condition. Current guidelines say, as Valerie mentioned before, that G2211 can only be billed if the associated E&M code does not have that modifier 25 attached. Concerns were raised, and now we have a change to that guidance. It's not a complete 180, at least we have a little bit of movement. So the final rule now is that you can now bill G2211 on that same day if the additional service is an annual wellness visit, vaccine administration, or other Medicare preventive service. Now, a year into using this code, there's two questions that we receive most often. What has to be documented, and are commercial payers reimbursing for this? I'll start with the second question on the payer. The answer is it depends. We've seen both. Some were quick to adopt the code. We've heard that others have not. So there's been some pushback. So we just recommend that you just check with your individual payers to confirm if you see any discrepancies there. Now, what has to be documented? The answer is there's still no specific requirements outside of the code description. CMS's response to this question, which is asked often, is that the content of the medical record, the overall documentation from the provider giving the context of the visit should in and of itself be that support for either scenario 1 or scenario 2 in that code description. Now, along with the final rule, we did receive an FAQ from CMS. So we've included that link for you here. We highly encourage you to check that out as well. And then lastly on this, I'll just mention, we mentioned it last time in the proposed webinar, but it's worth saying here again, just make sure that your claim scrubbers are updated. So if you have an edit in place, as it should be now, that anything with a modifier 25 auto rejects that G2211, just make sure that that's updated with these services here so that those do not hit an edit inappropriately. All right, next. All right, then G0545 is our newest code, another code for additional visit complexity. The idea is similar to G2211, but it's specific to the inherent complexity associated with treating patients with an infectious disease. We have provided the full code description here. I'm not going to read it for sake of time, but there's a few things we want to point out today. First and foremost, this is for services rendered inpatient or observation only. Okay, so double check your place of service before selecting. This is currently not applicable to office or outpatient. Like G2211, there's no specific documentation requirements currently, but again, the medical record should support that the work described by the code description is taking place. Now, what we do have in the final rule, thankfully, on pages 304 and 305, they've provided a very helpful expanded list to provide context on what each item in this code description is. So, you know, disease transmission, risk assessment, and mitigation. What is that? What all does that entail? I think in that list, there's about 7 or 8 bullets under that topic, and then they do that for each of the additional elements in this code description. So again, this is another element I highly recommend that you look at if this is applicable to services that you or your providers are performing. Last thing I wanted to note, it's not on the slide here, but we have received questions already on it. We've discussed it internally, so I want to make sure we comment on it. CMS comments in the final rule that the time associated with this code is 30 minutes. And they do this when new codes are established to sort of help identify the anticipated time involved in the service, but it's purely informational. G2211 also has a time associated, but time is not at all intended to be used for code selection or documentation. It's not at all a time-based code. So the question was raised, though, if a provider is selecting their E&M visit based on time, does that 30 minutes factor in? Does it have to be removed from that E&M time? And the answer is no, because it's not a time-based code. So all of the time spent on an E&M encounter would only go towards selecting your E&M code, even if time was spent on items that would help support that G0545. Okay, it's simply an add-on code to whatever E&M code is being selected. So hopefully that clarifies the discussion of time in the rule. And I'll turn it back over to Brian.
You're on mute, Brian.
Sorry, thank you, Valerie.
Yeah.
And thank you, Kimberly. The next thing I was going to talk about is some changes in reimbursement for preventive services. Also some changes in coverage, really, for preventive services for Medicare beneficiaries. The first of which relates to hepatitis B vaccines and administration. The big changes that Medicare is expanding coverage to include individuals who have not previously completed the vaccination series, as well as individuals with an unknown vaccination history. There's also no longer a requirement to have a physician order for the hepatitis B vaccine. And there's also a change to an increase to the payment rate for the administration code G010010. The $33.71 that you see is the national rate. That represents a 3.5% increase over 2024. There's kind of been some history there. Just a couple of years ago, there was just a flat national rate. Then it transitioned into there's gradual increases being applied, and then there's locality specific rates as well. So for purposes of this presentation, just have the national rate pulled in, but something to look out for as well in 2025. Then for relating to rural health clinics and federally qualified health centers, some changes in how these services are paid. Beginning in July of 25, Part B vaccination claims can be billed at the time of service and paid essentially like a traditional Part B vaccination claim. The current methodology, would be that these entities would report, provide the service, it gets put on the cost report, and then the payment comes in at a later time. So this would help. This change, I think, is a really good one and would help these services be paid in a more timely manner. These providers aren't having to deal with the gap in payment from when the services are furnished to where the payment is received for them. And then payment would, there's some, in addition to the timing, there's changes to the payment itself. So these would be, like I mentioned, paid like a traditional Part B claim, but they'd be paid at 100% of reasonable cost, and it would be separate from the other methodologies, other payment methodologies that are used by these entities. The next change in terms of preventive services relates to drugs that are covered as additional preventive services or DCAPs. Historically, these are not services that Medicare has paid for, or drugs that Medicare has paid for under this benefit category. But for 2025, there will be an implementing a specific DCAPS fee schedule, the specific details of which are not yet finalized, or the rates themselves rather are not yet finalized. But the framework and the kind of methodology of how this will be determined is. But the rates will be developed using existing Part B drug pricing methodologies, so the average sales price, and then there's a whole host of kind of a flow of how alternative pricing methods will be used depending on the specific drug and what data is or is not available to set that rate. So I'll spare you kind of walking through it, but you can see just if the ASP data is not available, then it kind of tiers down until it's ultimately, if needed, the price is just determined on a case-by-case basis by the Medicare administrative contractor. And then it's wanted to mention just lastly that same fee schedule, once that is finalized, would be used to pay for these drugs in RHCs and FQHCs as well. But those are in all of these changes are exactly the same as what was proposed. So everything was finalized, but no changes otherwise. And now I'll hand it over to Katie.
Thanks, Brian. I'm going to cover digital mental health treatment, or DMHT. So DMHT devices are cleared or granted de novo authorization by the FDA, and they're intended to treat or alleviate a mental health condition. And these include digital cognitive behavioral therapy, or digital CBT. So CMS created 3 new HCPCS codes to cover these services, and they're modeled on coding for remote therapeutic monitoring services. The first code is G0552, and this is the supply of the device and the initial education and onboarding per the treatment plan that augments a behavioral therapy plan. Keep in mind, this code is not payable if the provider does not furnish the device. So if the patient procures the device elsewhere, the provider could not bill for this code. Furnishing the device must be performed incident to the billing practitioner's services and in association with an ongoing treatment under a plan of care by the billing practitioner. The billing practitioner must diagnose the patient and prescribe or order the device. The second code is G0553, and this is for the first 20 minutes of monthly treatment management related to the patient's use of the device. It includes the professional's time reviewing the data gathered by the device from patient observations or inputs in a calendar month, and it requires 1 interactive communication with the patient or caregiver in the month. The last code is G0554, and that's each additional 20 minutes per month. Next slide.
Katie, any thoughts on, since these are G codes and Medicare is submitting them for use for potentially for commercial payers?
Not yet. I think we'll have to wait to see what commercial payers say about covering these codes. With them being new, I think it's a little too early to tell.
Mm-hmm. And I guess specific commercial payers will have whether they allow de novo or not regarding the FDA coverage, et cetera.
Next, I'm going to talk about interprofessional consultation for behavioral health providers. As you may know, there already are interprofessional consultation CPT codes, but they're limited to providers who are eligible to bill E&M visits. CMS believes these would be beneficial for behavioral health providers to provide. So they've created codes G0546 through G0551. And these can be provided by clinical psychologists, clinical social workers, marriage and family therapists, and mental health counselors. The treating practitioner and the consulting provider do not have to be in the same organization to furnish this service. And lastly, since these services are provided without patient involvement, Medicare is requiring patient consent be documented, so they're aware that there could be cost sharing of the services. Next, I'm going to pass it back to Kimberly.
It's interesting as we continue to add additional G codes for all of these types of additional services, and we have consents, layered consents for all of these different things that are going on. It'll be interesting how to navigate that with the patients. If they have, 5 different things that they're consenting for, they'll probably get a little weary after a while. So we'll see how that actually works.
Mm-hmm.
Yep. Signing your life away on some things, right?
Yep. Great.
All right, so let's talk about the supervision of outpatient therapy services. We've actually had a few questions come in already on this, so let's go over what has changed here. So under the current rule, the services provided by a physical or occupational therapy assistant in a private practice are required to be performed under that direct supervision, which simply means the supervising therapist is present in the office suite and they're immediately available. The final rule for 2025 is moving this to general supervision, which means the service is still provided under an overall direction and control of a PT or an OT, but they do not have to be present in the office. So the hope and the goal behind this change is to provide greater flexibility, not only for the therapists and their hours at their practice, but even more so for the patients, right? And allowing for better accommodation of the patient schedules, since it then frees up the supervising therapist to not have to be physically present with the assistant. So additional hours, after hours, things like that are benefits for this change. So again, this is welcome. However, the one important takeaway is to confirm your state level requirements. So although CMS is moving to general, this does not supersede the supervision requirements at the state level. So if your state still requires direct supervision, that will still need to be followed going forward until that is changed. And Katie, I think you're going back to opioid treatment programs.
That's right. Thanks, Kimberly. I'm going to be talking about a few changes related to opioid treatment programs, or OTPs. The first change is that CMS made permanent the flexibility, allowing periodic assessments to be performed via audio-only telecommunications for patients who are receiving buprenorphine, methadone, or naltrexone at OTPs. Secondly, CMS made permanent that the initiation of treatment with methadone billed with G2076 can be billed or can be furnished via two-way audio video communications. They feel like this will be beneficial for patients who maybe don't have a means of transportation or live in a rural area and it's just hard to get into the office. So I think these will be great benefits to these patients. Next slide. So a few other OTP updates. The first is related to HCPCS code G2076. This is related to the intake activities. CMS has revised the payment amount. They have increased it in response to recent regulatory reforms for opioid use disorder treatment finalized by SAMHSA to include an SDOH risk assessment at the intake. They have revised the code descriptor to be more inclusive of other types of professionals that could conduct the assessment in the OTP setting, and should be furnished by OTPs if they feel like it's medically reasonable and necessary to identify a patient's unmet health-related social need or interest for harm reduction interventions or recovery support, that type of thing. Secondly, Medicare is going to be paying for two new opioid agonist and antagonist medications that have been approved by the FDA. The first one is a new add-on code, G0532. This is for a new nasal spray that's indicated for emergency treatment of a known or suspected opioid overdose, and it is limited to billing once every 30 days. They have also finalized coding and payment for the weekly and monthly injectable buprenorphine. Lastly, in August 2023, the OIG released a report. They had done a Medicare audit on opioid use disorder treatment services, and they were seeing a lot of services submitted without an OUD diagnosis code. And so their recommendation was that CMS develop billing requirements that OTPs include an OUD diagnosis code on claims. And so Medicare is following that guidance and requiring that an OUD diagnosis code is included on claims for those types of treatment services. Now I am going to pass it on to Carine.
Thank you, Katie. Before I jump into what the final rule is for skin substitutes, I figured I'd take a stroll down memory lane. Skin substitutes are being offered both in the physician practices, but have historically been offered in hospital outpatient departments. And for the last couple of years, for 2023 and 2024, CMS has been trying to figure out how do they make consistent the payments for skin substitutes. If you're not familiar with how they're reimbursed in the hospital outpatient department, they are skin substitutes. The actual supply and material of that is bundled into the payment for the APC, which is part of the application of the skin substitute. And so what CMS is trying to do on the Medicare physician fee schedule side is to try to get to a consistency of essentially bundling the skin substitutes into the payment for the application. But you can see how that could cause some discourse and some concerns of how that reimbursement significantly impacts providers. In addition to that, CMS in the last couple of years has proposed some new skin substitute product codes, and they're trying to work with various organizations that are responsible for creating skin substitutes and determining how best to move forward. So they've decided to do this in a phased approach. So this phased approach started in 2023. Since then, nothing has been finalized from a payment perspective, either in 23 or 24. So next slide, please. As we look forward to 2025, we're kind of in that same boat of nothing has been finalized. However, there were some good points made regarding payments and refundable drug components related to the billing and payments for skin substitutes. So first, I'll talk about the payments component piece. So while Medicare continues to consider making changes to the Medicare Part B payment policy for skin substitutes, they haven't finalized anything as of right now. However, while nothing has been finalized for these products for 2025, there were several comments received from individuals related to the ways of achieving consistency in the payment models for skin substitutes under the physician fee schedule. Some of those examples include implementing a maximum of 150 per centimeter squared reimbursement for all A and Q codes for skin substitutes, which Medicare said that they would take into consideration. In addition to that, one commenter actually included or recommended replacing the current skin substitute application codes with codes that describe the more complex wound procedures. The concern really is that the alternatives that are being provided or recommended within the comments helps kind of suggest moving away from bundling of the skin substitutes into the application codes, because that reimbursement is significantly low. And from a provider's perspective, every patient is going to be different. The treatment is going to be different. The required skin substitute that they are utilizing is going to be different. In addition to that, Medicare was considering, could they pull skin substitutes under the supply component or the practice expense RVU, which again is not beneficial to a provider, but also not beneficial to a patient, because it reduces their ability to receive that service from a provider practice as wound care and skin substitutes kind of expand beyond the hospital outpatient department. The other part of the consideration for 2025 is related to refundable drugs. That was actually the only item that was finalized for 2025. CMS continues to say that skin substitutes will not be counted for purposes of identifying refundable drugs for 2025. If you're not familiar with the thought process behind refundable drugs, essentially when a provider or a hospital bills to Medicare for certain drugs that are administered to an individual under the Medicare Part B, Medicare pays that provider for both the administration and the discarding of the amount of the medication. Under the drug refund policy, what Medicare is saying is that the manufacturer would have to refund CMS for the certain amount of discarded medication. So what they're saying right now is they're not including skin substitutes, understanding that skin substitutes are not always 100% utilized, or portions or pieces of it that are not utilized and they are discarded. So providers are not having to report the modifier associated with that. But while it's not considered for this year, they have kind of considered it in proposed rules in 23 and 24. And they've explicitly stated within the final rule that they will continue to consider it for future rulemaking. So from a skin substitute perspective, it's important for when that proposed rule comes out in 2026, the payment considerations, the refund drug policy considerations for skin substitutes, I feel very strongly that they will be in there. And so comments will help kind of, give guidance to CMS on what would be the best approach to make sure that skin substitutes are reimbursed properly within that provider setting, but also being able to make sure that that service is still available to patients in that office setting as well.
Yeah, this is a big challenge because they're trying to create policy around this, but there's already enforcement occurring. So, practices that are doing these services, there's, the cost of these services, a lot of these skin subs are, $100,000 or more. And so to actually be able to provide this underneath the administration would be nearly impossible for an office setting, right? So it is going to be a challenge between now and the time that they come together with a policy and being compliant. So we would encourage you to really make sure you're tying down everything on what the expectations are for each payer and how to address each payer, and not just taking kind of the vendor's expectation of it, but really looking into this and evaluating how can you do this compliantly so you don't end up in an enforcement scenario or audit scenario, because there's a lot of that going on right now in this area. All right, anything more, Carine?
Nope, that's it. I'll turn it back to you, Valerie.
Okay, great. Well, we want to, I passed the slide. So we want to make sure that you're aware of our upcoming webinar. Our final, the third part of this final rule segment is on December 11th. So tune in for that, or listen in after that's recorded. But also tomorrow we have a Let's Get Rural series, if you will, that is underway and is going to give you a regulatory update. So if you have any RHCs or FQHCs, or you are one, then please tune into that, because beyond the fee schedule update, there will also be, additional concepts regarding HIPAA and other areas that are of concern to you. So we welcome you to tune into that tomorrow, or listen to that later as well. And there are credits actually available for that also, which can be helpful. So I will turn it back over to Jen, and we really appreciate everyone tuning in today. Thank you.
Thank you for listening to this PYA webinar recast. The video recording, slides, and associated material for this and all PYA webinars are available on our website. If you have any questions or if we can help, please contact us at pyapc.com. Thank you again for joining us, and have a great rest of your day.